Good morning. We're here in lovely Napa Valley at the 7th Annual Cardiology Napa Valley Conference. I'm here with Dr. Lars Svensson, who is the chairman of the Heart Vascular Institute of Cleveland Clinic. As some of you may know, we have an official partnership with Cleveland Clinic here at Piedmont Heart Institute as one of their affiliate sites in their national network, and have loved taking advantage of the lessons we've learned from Cleveland Clinic in their leadership in all of cardiovascular medicine. Dr. Svensson just gave a very intriguing talk, which is why we grabbed him out of the crowd to come meet with us about valve replacement therapies. We won't go into the intricacies of his discussion as it relates to TAVR or SAVR or who should get what and what the longevity was, but it was really the thing that caught my attention in his discussion was this transition that is upon us as a cardiovascular community of not only do we figure out who should get which therapy, but how we should manage the whole the collection of resource that is being basically put in our lap by these changes in the healthcare law. So you gave some very intriguing, put some intriguing slides up about we've got these great therapies, and my sense was the government has said, we're going to give up on figuring out who should get a therapy or not, and we're going to give this pot of money to the healthcare community, and you all figure out how to manage that money and who should, in essence, get the care, which in my interpretation from your discussion is the rationing is upon you. You guys figure it out.
Well, it's a pleasure to be with you and to be chatting, and Piedmont's a great partner with the Cleveland Clinic, and as much as we hope to help other people learn from what we do, we inevitably, when we go and meet with other people, as we did when we went down to Piedmont, we learn a lot of very good lessons from our partners, whether in the network or the affiliates. Yeah, so we are entering a time of tremendous change in healthcare. It has taken some time for all the things of the Obamacare, the Accountable Care legislation to roll out. And we're seeing a number of things. But as we talk about this, what I've been telling my team at the Cleveland Clinic and Heart Vascular Institute is that, yes, we have to change because there's this huge tsunami of change that's coming from fee-for-service to value-based purchasing type of episodic care. So we have to change. We have to innovate how we deliver care, not only in finding new devices like TAVR, and new devices that make for more efficiency, but we also have to bring the costs down. And at the same time, preserve research, preserve education for our residents because they are the future. And then what has to be untouchable in all of this is patient care, outcome, patient value, as it's often called. I think more patient satisfaction, that they understand we do everything possible for them to give them the best care. And the challenge as we get under more and more pressure to deliver so-called care efficiently and make it affordable, reduce costs, whatever one wants to use as a term, is that we take care of the patients the best way possible. And what I say to our team is that the moral question you should ask yourself is, if I do this, will it affect a patient's outcome? And if it is, then we shouldn't do it. So clearly the things that are happening as broad trends, there's a demographic issue in that we've got 77 million baby boomers retiring, and they are now moving from commercial insurance into Medicare. That has a lot of implications. What we're seeing now is a lot of the insurance companies are beginning now to get into different businesses because they already have made the transition that most of their business is going to come from the government. And 3-4 years ago, I made the prediction that in 10 years' time, which is now 7 or 6 years' time, 75% of reimbursement in the United States for healthcare is going to come from the government, whether that's Medicare, Medicaid, CHOP, TRICARE, et cetera, and the consequences of this are also that as the patients get older, they're no longer on good commercial insurance. They are now moving into Medicare, which means less reimbursement for hospitals. Many of them are putting off, for example, knee replacements for a year or two, because once they get into Medicare, they don't have these tremendous co-pays that can be up to $6,500. So that's another reason why they're putting it off, which puts financial stress on institutions. At the same time, there are a lot of projects like the ACOs where institutions are required to take a certain number of Medicare patients, and they get a set fee and they have to treat for those patients whatever happens to them. The result is a bit like the HMO model. Now you have lots of primary care doctors taking care of those patients. And we're working on how do you communicate with a specialist to get the best care for the patient, but not overutilize the specialist, which is once again going to be an issue for cardiologists and for cardiac surgeons down the road, because in a sense that expense comes out of the pot. So that's another challenge going forwards. As you mentioned, the government's giving us money and we have to then do the best we can with that money going forward. And then we get into the issues, as we discussed this morning, of percutaneous valves. And my calculations, sort of back of the envelope, were that about $4 to $6 billion would potentially be spent on percutaneous valves if there's full penetration of the percutaneous valves. Now, that's aortic valves, mitral valves, tricuspid valves. And if that happens, the importance is that in 2015, the government, CMS, spent about $205 billion on Partner A of Medicare. In other words, what hospitals get paid. Hospitals now have to pay from their DRGs for these valves. And for the percutaneous aortic valves, the two commercial ones, that's $32,500. That comes out of the DRG. So most institutions, particularly the ones in the center of the country, not so much the coast, but even the coastal ones, are losing money on these devices. Now, if one adds that all up then, is the government going to allow full penetration of percutaneous valves in the elderly population, because that's what it's mainly going to be, and rack up $4 to $5 billion, 2 to 3% of what they currently pay to hospitals? And I suspect this is going to be part of the challenge that we'll face with CMS reimbursement for intermediate or even low-risk patients as far as full penetration for aortic valves, separate from all the issues of potential complications related to percutaneous valves like high pacemaker rates, perivalvular leaks, untreated disease, etc. So those are issues that we'll have to face, and we don't know the answer to that.
Right.
And we'll have to see how it goes.
It's going to be interesting because the TAVR, as an example, is something I think that is really pushing systems to finally act as a system, and trigger care pathway development, a real scrutiny on length of stay analysis, and put all those pieces in place that I don't want to say force, but require the heart team to act as a concentrated team, with a goal in mind. As an example, after our partnership, our length of stay in TAVR came down almost from 11 days at the very beginning to almost 2 days currently. But that was a very comprehensive, multidisciplinary exercise in order to do that.
Yeah, and that touches on a couple of things. As you point out, reducing a hospital stay is obviously critical, but then you get into a problem that the DRGs will pay you the full amount only if the patient's in hospital for 4 days and does not go to rehab. So if a patient stays in hospital 2 days, goes to rehab, you lose $14,000 for the first day of transfer to rehab. So we've got this sort of absurd situation that, at least for patients who are potentially rehab patients, we have to keep them in hospital at least 4 days.
Doing the right thing.
You get penalized for that aspect. I think the other thing that you touched on that's very important is the teams are working, I think, in my perception, very well in most academic institutions, where there's good discussion about what is best for this patient. Right. And that, to me, is a key part of what we do, is making sure that the patient gets the most appropriate care. And that certainly has been one of the consequences, I think, of the TAVR project and the heart teams, which in a sense have been revived again, because we used to do that for PCI and PTCA in those days. You know, we'd all review them together, be on standby for in case of perforations or whatever. And so I think it's good that that's come forwards again.
And that's been, it's interesting because, you know, this meeting as an example has kind of reflected that transition where several years ago, as you say, we were, you know, we had an interventionalist present something or a surgeon present something, and we actually changed the format under Manny's leadership that this is all heart team education, you know, and that the heart team approach is emphasized. But, well, thank you for those comments. It was a nice summary from your talk.
It's my pleasure. It's great being out here, and super conference, and very high-powered talks, and very thought-provoking. So great job.
Well, we appreciate your partnership, and Cleveland Clinic is a sponsor of the meeting and a partner in the meeting content, and we look forward to continuing to grow and have this be an important meeting on an annual basis. So thank you.